So in this video, we're just going to look at the active range of motion of the lumbar spine and just some key points that we're looking at when you're observing the active range of motion. So with respect to flexion, what you're trying to do is look at segmental flexion. So usually you'll instruct the patient to lead with the head, then round out the shoulders, and then continue with the rest of the motion. Now, as they flex forward, you're looking at the lumbar curve reversal versus the thoracic. So you want to see an even, curve opposed to some areas of potential hyper or normal mobility and areas of hypomobility. You're going to reference where the fingers are, how far down they can reach, and you can come back up. So you want to maintain full knee extension, feet just shoulder width apart. Again, let's do one more time. Lead with the head, round the shoulders, segmental motion. You can instruct them, move one vertebrae at a time. You're trying to do that to avoid a hip hinge pattern. You want them to be able to see if they go through a segmental rotation or a segmental flexion, is it normal lumbopelvic rhythm? And what are the natural, curve points that you see, or are there areas of potential hypomobility? You also want to get a symptom response. If there's just tightness, is the tightness in the hamstring? Is it equal bilaterally? Is there back pain? Is the pain during motion? Or is it at the pain at the end of the range? That's important to note. If they feel pain, is it just local to the lumbar spine, or do they have any distal symptoms? Not stretching in the hamstrings, but pain in the leg or foot or paresthesia or anything like that. So you want to make sure you get a full description of what the symptom response is during each motion. So with respect to measuring motion, typically if you're looking for curve reversal and you can document what you see and you can make sure the knees stay extended and you can reference how close the fingers are to the floor, that's sufficient when it comes to a quantitative and qualitative blend there. So with extension, feet shoulder width apart, hands on the hips, and this is similar. You're thinking about more of a segmental extension. They can, if the neck allows, they can lead with the head. You want the knees to remain in extension and to bend backwards as far as possible. This is similar. Now, what you're looking for here is the inferior border of the scapula. You want to see if it can clear the heel, and if the ASIS is able to clear the toes, is what you're looking for here. You can come back to neutral. So that would be considered a field test. You can use a goniometer or an inclinometer on the sternum, but this would be a quick field test of a way to look at how am I gauging full range of motion. Can that inferior border of the scapula clear the heels, and can the ASIS clear the toes with the knees maintaining an extension, and looking for an even curve throughout the spine, and again, getting your symptom response. The last piece, if you extend one more time, the last piece that we're looking at in the frontal plane is if there's any deviation. You're looking to see if one shoulder drops lower than the other, and come back. If it does, sometimes that can suggest a unilateral hypomobility, and that might be something you'd want to look at in your passive accessory exam. Now, facing me, we have a side glide. So what you're going to do with a side glide, again, your feet shoulder width apart. Your arms are going to maintain parallel to the floor. The knees need to maintain extended, and the hips are going to glide to one direction as far as possible. You cue them to further, push, push, push. How does that feel? Now you can come back to neutral. Now you get a symptom response here, but at the end of the motion, if there's no pain, you would want to add overpressure to their hips. So you can apply a pressure. That's what the clinician's hands would do. The clinician's hands would apply a pressure in that direction to overpress if it was an asymptomatic movement. If you do that one more time, maybe do the other side, hips to the right. This would be called a left side glide. It references the trunk, not the direction of the hips. Now, the other thing you're looking at is if there's any kind of a rotation. So sometimes patients there could be a hypomobility in the hip, and they might start to rotate somewhere. So you want to make sure that they are staying true to the plane of motion as you're looking at this movement. The reason that we look at a side glide is because this is more of a lower lumbar movement, where a side bend is going to be more of a top-down movement, more of an upper lumbar movement. So this is also valuable to look at. Again, you're just looking to make sure that they don't deviate into the frontal plane by flexing forward like this, which will allow them to go further. So you need to cue them to make sure that they are purely in the frontal plane. You're looking for even curve, and you want to see how far can the fingers go down to the knee. If you turn around and face the other direction and side bend, this is where we can look at an even curve reversal, or not reversal, but just an even curve of movement. Or do we see that there's, let's go the other way. We want to see if there's, so that's a nice even curve right there, symmetrical, and we don't see any areas of hinging is what kind of we're looking for with that motion. Now, if you turn around, the last movement you can look at, there's not a lot of rotation in the lumbar spine. There's just a couple of degrees per segment. So if you look at rotation, you just have to appreciate that rotation is going to be the byproduct of ankles, knees, hips, lumbar, and thoracic movement. But if you put your hands on your hips, you put your feet together, you keep your knees fully extended, and you twist to the right as far as you can. I'm looking to see if the back shoulder, I'm looking to see if this shoulder, the right shoulder during right rotation, can I see it? And come back. I'm looking to see if the pelvis, if you rotate again to the right, I'm looking to see if the both ASIS can clear 45 degrees of motion. And if I can see that posterior shoulder. If I can't, you would consider there might be a hypomobility up in the trunk somewhere. If you rotate the opposite way, and you can see here this side is more mobile. So we have an asymmetry in rotation. Now, if you look at the ASIS and that clears 45 degrees, but the trunk does not, you can start to isolate where the range of motion limitation might start to be and where you might need to look further.